All right, this is part 5 of the musculoskeletal conditions series and last, and we'll be looking at juvenile rheumatoid arthritis, or JRA. Juvenile rheumatoid arthritis affects quite a few children in the United States, 300,000. And so it's something that is fairly, it's not real common, I guess, but I guess in my time practicing, I've known about 3 children who have been significantly affected by JRA. Um, the definition is very similar to that of arthritis. So you have your joint inflammation and stiffness. That joint inflammation and stiffness and pain usually lasts more than 6 weeks, so it's something that's considered more chronic. If you think of somebody having joint pain or stiffness, maybe because they overextended themselves with playing, or maybe they sprained something doing a jumping jack or a cartwheel or something like that, that's where if it were just something similar to that, that would have healed and have moved on after about 6 weeks or so. And so here those symptoms are lasting longer than that. This affects children less than or equal to 16 years of age. So to get the diagnosis of JRA, you have to have the symptoms prior at the age of or prior than 16. And it usually begins as early as 2 years and 4 years of age, and it's more common in girls at this particular age. As with any arthritis, it is considered an autoimmune disease. And so that means that the body's immune system is starting to attack its own cells and tissues. And so with arthritis, basically, there's white blood cells that lose the ability to tell the difference between what's healthy and what's an invader, like a virus or bacteria. So the immune system releases chemicals that are trying to fight off those bacteria and viruses because the body is interpreting healthy tissues and healthy cells as something that could damage. And so they're sending off their attackers, right? And basically their body's fighting itself, and that causes a lot of inflammation, which then settles into the joints, and it can be very, very, very painful and cause that stiffness. There's no known cause. They do think that it can be genetically predisposed, and there's talk even about environmental factors, such as maybe different viruses or being exposed to different viruses at certain ages, that may be attributed to JRA. All of the cases I've known of JRA, there has not been any family history of it, unless, again, people didn't know about it, and, oh, yes, this child just has some pain or whatever, and after generation, it just wasn't picked up on. So the symptoms can be very subtle, or it can be very obvious, right? It can be maybe just some limping, and a parent's like, huh, I wonder, they must have, they must have stepped wrong or something like that on their ankle. But that limping can be an early warning sign. You may have a child complaining of sore wrists, fingers, or knees. A couple of the kids I've worked with weren't able to complain, but we saw them kind of rubbing their wrists or shaking them out, shaking out their hands. We saw them limping. When we started seeing wrist swelling and ankle swelling, to the point of it being very enlarged and very red and warm to the touch, we knew there was something going on. We knew that it was sort of either arthritis or something with autoimmune. You may have stiffness in the neck, hips, or other joints as well. There may be rashes that occur. They may appear or suddenly disappear. developing in one area or another. There may be, and you may even think that the rash is from a fever. Okay, because of the body fighting itself off, naturally your body creates fevers to help sort of kill the bacteria or viral invaders in our body. And so since this is an autoimmune disorder and our body is interpreting healthy cells as bad cells to fight off, you may see these kids having a fever quite often. You may see swelling of lymph nodes. There may be even eye inflammation. In particular, there's different types of JRA or different categories of it, and there's one called pauciarticular, where eye inflammation is very common, and because of that inflammation, it could lead to blindness, unfortunately. So in pauciarticular JRA, you may see eye inflammation that leads to blindness. In severe cases, the growth of the affected joints may occur too fast or too slow, causing one limb to be shorter or longer. So again, with JRA, you may or may not see some of that limb abnormality and those kinds of things. With JRA, very similar to regular rheumatoid arthritis with adults, you'll have people that go into flare-ups where they're going to have very high fevers. They're going to have stiffness, and their joints are going to be swollen. They're going to have more pain, and then over time that may dissipate, and they go into periods of remission where the arthritis is still there, but it's more of an inactive period, and they usually feel better. When they diagnose JRA, they usually take a very thorough medical history. Again, there may be some genetic component to it. They'll take a look at x-rays to kind of see what's going on in the joints. They'll take blood tests to rule out other conditions, such as, is it a fracture? Is it a physical injury? Is it a sprain? Is it any ligament damage? Is there an infection that's going on? Some infections sometimes you can have, the skin swell and get very hot to the touch and red in nature. Lyme disease is characterized by some joint inflammation and pain and those sorts of things. Lupus, childhood cancers. So basically they have to do blood work to rule out, and take x-rays to rule out some of these other conditions that are quite common in children as well. Other tests that they may do is look at CBC, or a complete blood count, and they're going to look at all the cellular components of the blood, including red blood cells, white blood cells, platelets. And so different abnormalities or different appearances of these cells can be useful when diagnosing many medical conditions. So if there's a white blood cell spike, that may signify some sort of an infection or some sort of autoimmune disease. Erythrocyte sedimentation rate checks how rapidly red blood cells settle back down to the bottom of, say, a test tube. And so the rate often increases in people when inflammation is occurring. So if their pain is associated with inflammation, they're going to have an increase in that sedimentation rate. ANA is called anti-nuclear antibody. Anti-nuclear antibody. And so again, this is similar, or this is a blood test that uses, or that detects autoimmunity. So it's useful in predicting children who are likely to have an eye disease, again, that pauciarticular one, quite importantly, with JRA. So they may do an anti-nuclear antibody to test for, or to predict children who are likely to have eye problems with JRA. Bone marrow examinations allow doctors to look at where the blood is formed, which is in our bone marrow, to rule out other cancerous conditions such as leukemia. And they may do bone scans to detect changes in bone and joints to evaluate causes of maybe unexpected bone or joint pain. Is it bone density? Is it any other cause that could be occurring here? So those are some tests, a variety of tests that they do to sort of rule out other particular conditions and sort of kind of culminate into, yes, it's autoimmune, yes, it's related to the joints, yes, it's JRA. Again, different types of JRA. There's polyarticular, and so with polyarticular, it affects 4 or fewer joints. Um, the larger joints are the ones that are most affected. So maybe the shoulders, or I'm sorry, the knees, hips, ankles, maybe elbows. With polyarticular, it can affect the joints on either the left side of the body or the right side of the body, so it may not necessarily be symmetrical, and it often affects girls under the age of 8. And there may be few or not even any systematic manifestations, so they may not have a fever, they may not have a rash, those kinds of things. Idiosinclitis or iridocyclitis is that chronic eye inflammation that can lead to blindness if not treated. And so polyarticular usually affects fewer joints. There's not a lot of systematic manifestations such as fevers, rashes, those kinds of things. But we really have to watch out for that chronic eye inflammation because we don't want them to become blind if at all possible. So a lot of care should go into that anti-nuclear antibody test to help predict this issue. The prognosis is good with this type of JRA because such few joints are affected, and polyarticular JRA is likely to go into more early type of remission. Polyarticular can have an onset at any age. Again, with the diagnosis, it's 16 or under. It affects more girls than boys, and it affects 5 or more joints, and sometimes even the smaller joints, such as the fingers, the smaller joints in the wrist, as well as the knees, hips, ankles, feet, and neck. They generally have a low-grade fever. They have malaise or fatigue. Sometimes they're listless or restless, and it is symmetrical. So both wrists may be affected, both hands, both ankles. Some children have an antibody in their blood called the rheumatoid factor, and so they may do a blood test, and if they have this RF factor, usually it means that it's a more severe form of the disease, and it would be very similar to adult rheumatoid arthritis. So the antibody test that they do for adults with rheumatoid arthritis, if they run that test, it may signify a more severe type of JRA. The prognosis is good if they have a negative RF factor, but unfortunately it's poor if they have a positive RF factor, because that means it could lead to a more disabling type of arthritis. So with polyarticular, it affects more joints. It affects the smaller joints. There's a fever associated with it. And they can do that RF factor blood test, and if it's positive, the prognosis may be more severe than if it's negative. Systemic JRA is equal male and female ratio, and again, it can occur at any age. Unfortunately, it can affect the whole body. This is the least common form, and here they have a very high fever. And so during this fever, of course, the child may look very ill, they may look pale, they may have rashes or have red pale spots on the chest and thighs, which kind of come and go. When they do blood work, they may find that the spleen, the liver, lymph nodes may be affected. Over time, many of the body's joints have pain and swelling and stiffness, and as a result, they may have some anemia as well, which is going to contribute to some fatigue. They could have a very high white blood count, and their prognosis, unfortunately, 50% develop a severe chronic arthritis that has very reoccurrent systemic manifestations. So they may continuously have periods of high fevers, low fevers, anemia, those kinds of things. A lot of the prognosis, a lot of people with this type of JRA have other types of infections. They are going to have significant inflammation. They're going to use various types of medications such as corticosteroids, which unfortunately with long-term use of corticosteroids there's additional side effects to that. They may use antibiotics, maybe anti-seizure drugs. They may use in one of the videos that I assigned and found, they actually were using chemotherapy drugs, and so they sometimes have to kind of pick and choose and sort of experiment with what kind of drugs they're going to use. So unfortunately, the prognosis isn't as positive with somebody with systemic JRA. So what we do in OT, as well as medical treatment, is try and control that inflammation. And so the medical treatment of that, controlling inflammation, may be use of corticosteroids, or use of chemotherapy drugs, or use of there's specific drugs related to JRA and arthritis for that inflammation. And so if you control that inflammation, you may be relieving pain, okay? So again, as medical management of inflammation, they may be prescribing some of the drugs in medical management. As OT, there are certain things that we could do to control inflammation as well. We may use cryotherapy, such as the use of cold packs, which would cause some vasoconstriction and allow some of that inflammation to be pumped out of that system. If you get rid of that inflammation, you may have that relief in pain, okay? Just with personal experience, having things that are extreme temperatures for people who have JRA, you want to avoid. So if you use something that's very, very, very cold, because yes, they're in an inflammation state, it could be a real shock to their system, and they may not like it, and it may cause more of an ache versus more of relief. What I've used that's sort of helped is using a combination of heat and cold, or lukewarm and cool. And the theory behind that is you don't want to use such a great amount of heat during that inflammation phase, because that's only going to increase inflammation. So I don't want it super hot. But using some heat may reduce muscle spasms. It's going to open up the blood vessels a little bit more, and then when you go to put it into the cooler water, those vessels are going to constrict. And then you put it back in the warm water, and then those vessels will open, and then it'll relieve stiffness, and then you put it in the cool water, and those blood vessels will constrict again. So that constant constriction of the blood vessels and dilation of the blood vessels should act as a pump and sort of pump some of that inflammation out. Again, personally, I try not to use such extreme temperatures with people with arthritis, because again, with real warm things, you're going to maybe even increase that inflammation, which you don't want. I've had luck with those with pediatrics. With adults, I've used things like moist hot packs, paraffin baths, maybe some ultrasound, some of those types of modalities. But again, with ultrasound with kiddos, you don't want to go over their growth plates of their bones, because then you could prevent growth, right, of their bones. Paraffin baths I tried with kiddos, and it seemed like it was too much of a too warm for them, and so instead I would do those contrast baths, and it sort of I had better luck with those. Preventing and controlling joint damage. So your Case Smith text has some very good joint protection strategies, okay, using larger joints to complete things. And so this may lend itself to teaching people how to dress themselves, or teaching them different ways on how to grasp their pants to pull that up, or increasing or building up utensils so they don't have to squeeze so tight and cause further joint damage or joint pain. One of the things that I also utilized with a couple of my kiddos with JRA was some splinting. So they tended to try and keep their hands in a flex position and their wrist in a flex position because of pain. Kind of like, if I have a stomach ache or something like that, I may kind of lay down and sort of find myself in crunched fetal position. And with JRA, sometimes that pain doesn't go away. And so they may prefer that flex, more guarded position. And so, the issue with that is if you have that flex position for so long, that joint is going to get used to that. And then you may have some soft tissue shortening on the flex side. And so then it would be harder to extend your arm or extend your fingers. And so sometimes I would use some soft splints, some neoprene splints, to sort of open up that web space. The compression of that soft neoprene splint helped with inflammation as well, because if there was some compression around that joint, it would help control some of that inflammation. Also, it would put the hand in a more functional space, so they could use their hand more functionally. And so the neoprene splints that I used, they were from Benik, B-E-N-I-K, Benik hand splints, and they were more of like the thumb spica, and you can get them so they're a little bit longer and cover the wrist. So again, they would have more compression around that painful joint. As OTs, we'd also want to maximize their functional abilities. So again, is there anything we can adapt to make them more independent? Is it easier for them if they're having shoulder pain to maybe don a wraparound sweatshirt instead of a pullover t-shirt or something along those lines? Are there joint protection techniques? Are there energy conservation techniques that we can do to sort of help them? Sometimes we'd also do some strengthening, but I was very, very cautious with strengthening, because the more strengthening you do, strengthening requires resistance, okay? And so sometimes when you do too much resistance, you can increase inflammation and pain also. So it was very challenging, trying to increase hand skills in a little girl who was about 3 or 4 years old with JRA. And so, if she started shaking out her hands or rubbing her hands or saying "owie," I needed to back off with some of that extra exercise and those kinds of things. So sometimes you would just do range of motion without resistance, just to get those joints moving, those sorts of things. Let's see here. For medical management, a lot of times they may use some of the NSAID pain relievers like ibuprofen, naproxen, to sort of increase or decrease that inflammation. Corticosteroids are used a lot, like prednisone, which manage, overwhelming inflammatory or systemic illnesses. But again, some of those need to be taken into consideration, and the physician would do that because there can be some long-term side effects of that. DMARDs, disease-modifying anti-rheumatic drugs. Methotrexate is one that's very, very common. Again, it has some pretty significant side effects. And so the particular kids I worked with that were using medicines, they had prescription strength ibuprofen that they did throughout the day. They had corticosteroids, and then they would take corticosteroids, and then they would take a break from corticosteroids. They would start corticosteroids, and then they would take a break, again, because of the long-term side effects. And same with methotrexate. Some of them, when the corticosteroids weren't working, they would use methotrexate, and some of them would use a combination of all three of them, which was very stressful to one of the mothers because the little girl just, what was it doing to their organs, those sorts of things with these heavy-hitting drugs. As I've talked about OTs, we're going to look at activities of daily living such as dressing, feeding, toilet transfers, toileting hygiene. We may be looking at range of motion. We focused on upper extremity range of motion in our clinic. We used adaptive equipment, adapting pencils to build up pencils and crayons. We did splinting. We did modalities to try and decrease pain. We did home programming to do contrast baths at home, and active range of motion, passive range of motion to some of her joints within her pain tolerance or comfort. We adapted clothing. We adapted all sorts of things so that they could be independent with her occupations. Physical therapists were also involved, and a lot of times they did range of motion. In our clinic, the PTs did range of motion of hips, knees, ankles, toes, those sorts of things. And so they also tried to do some strength and endurance types of exercises. They also did modalities on the lower extremities, like paraffin or hot packs to the legs. It seemed like the kids tolerated those better with their legs than what they did with their upper extremities. On both PT and OT, we did various exercises. Again, a very fine line between how much resistance do you give versus not. If you have arthritis and you don't move, there's inflammation. If you have arthritis and you exercise too hard, you're going to increase inflammation. And so there's not a recipe for how hard to push these kids. You have to really use your clinical reasoning, your observations, and kind of go with it as you move forward. Seating and positioning may be something too. If a person is in a wheelchair, maybe they are going through a flare-up or an exacerbation, and maybe you recommend that they have a seating system to prevent further fatigue. And so there you would have to look at a seating system and pressure reducing cushions and those kinds of things. Overall, with treatment, there may be complementary and or alternative medicines such as various supplements, maybe special diets, acupuncture, massage, those kinds of things. And one of the girls that I saw, a young girl, her mom after therapies took her over to a chiropractor where they did acupuncture, and she felt that it helped. And so she felt that it helped. That was what mattered. So, the science behind that, I'm not sure. But again, that family was very satisfied with the acupuncture, and so it wasn't me to say that it did or didn't work. Um, so to try and help you with kind of case scenarios and stuff. Cases are very time consuming for us to come up with a case with every condition, but based on the student feedback, I wanted to try and give you a case. Again, I've had a few kids that I've worked with, 2 girls and 1 boy with JRA. And so I gave you a little scenario here of a 10-year-old boy. He's in his acute phase of polyarticular JRA. His problem list, he's got decreased fine motor problems because and it's affecting his ability to get himself dressed. And so just some strategies to assist. Maybe a wraparound shirt would be better if his shoulders are affected. For him, it's just decreased fine motor. And so for him, just wearing pullover shirts may be better, and elastic pants. Maybe their shirts instead of snaps, which would be very hard for him, or buttons, maybe they can adapt it with Velcro. Teaching the child to use larger joints. So if there are snaps and he doesn't want to do Velcro, maybe using the palms of his hands instead of his fingertips, and using zipper pulls as well, because it's a larger item to grab, and he can grab with his whole fist versus just his fingers. Prognosis varies. There's a wide range. All of the three children that I worked with, every single one of them actually did go into remission at one time or another, and none of them have had another flare-up. So that's encouraging. The largest percentage of children with polyarticular JRA completely recover within 1 to 2 years. 15% of children with JRA do have permanent disabilities, and again, the 3 children that I've worked with, none of them have. Story that I came up with. Samantha's a 7-year-old who enjoys playing outside, dancing, being with her family. She started to have pain in her knees, ankles, and elbows. She holds her arms in a flex position and seems to feel more comfortable. And she is in the acute phase of her JRA. Samantha saw the doctor and was diagnosed with JRA. And so just on your own, for your own case, here's some questions. What type of JRA do you think Samantha has? Do you have concerns? What are your concerns regarding her flex posturing? Do you think she'll recover? And what kinds of activities would you avoid during the acute phase of JRA? And again, that Case-Smith joint protection reading assignment may come in handy. Here's a couple related videos of JRA for that personal story, that personal touch. And let me know if you have questions. Thank you.